just on CMEs and any concerns you have, please get in touch with Rana. I have nothing to disclose. I have no financial arrangement with any information I'm going to be presenting today. We're going to talk about cognitive behavioral therapy, specifically some relapse prevention components. And this is a lot of information. And of course, I'm starting late, so I'm going to try to run through it as quickly as possible. But you'll be getting the slides afterwards. And if you have any questions about anything that I cover or maybe don't get to, please feel free to reach out to me. I'm happy to talk with you afterwards. But I'm going to go over the basic components of CBT, and I'll move through that pretty quickly. And then I just want to give you some examples that fall in the relapse prevention CBT category of exercises that could be pullouts that you can use kind of regardless of your role with the patient. So we'll go over trigger and trigger identification, urge and craving management, behavioral contingencies, and high-risk prevention planning. So I just kind of want you to see some of those pieces. Now, CBT is just like we talk about when we're treating individuals with substance use disorder. In other lectures, we talk about there isn't a one size fits all. There isn't one intervention or one model that is going to work for everybody, because people that are in the process of changing their relationship with substances of abuse are in this stage of change cycle, right? They're falling somewhere between pre-contemplation and maintenance. And we need to assess where they are in order to determine which intervention strategy is going to be most effective. So when we're talking about CBT skills, both at kind of earlier in treatment, and then really where we see a lot of bang for our buck is in the maintenance phase, where relapse prevention fits in. We're really looking at hitting people somewhere between planning and maintenance with these CBT strategies. And then for relapse prevention specifically, it's going to be most effective once somebody is firmly in action and moving into maintenance. So that means that they're committed to making the change. They're already taking steps to decreasing their use. And so a lot of the skills that we're going to go over are really helpful at maintaining that for the long term and helping them to achieve long-term recovery. This is another model that shows you where CBT really falls. Early on, we're going to use harm reduction strategies or sometimes motivational strategies for patients. And then once they're moving into that sort of planning, action, and maintenance, that's where CBT can be really effective to help them identify their triggers, identify warning signs and high-risk situations, and then what are the things that they need really for long-term recovery, because it's more than just the absence of using a substance. It's how are they going to be a well-rounded, healthy individual in general. And then relapse prevention skills are part of that CBT umbrella that really solidify and help people maintain that change for the long term. So when we're talking about CBT, what does that mean? In a nutshell, it means it's a talk therapy that really links thoughts, feelings, and behaviors together and teaches a whole set of techniques that are aimed at helping patients understand that chain. In general, there's a number of manuals out there, a number of protocols for every type of substance use disorder. But in general, these can be really flexible. You can pull out individual sessions. You can implement them across multiple sessions or just in a one-time session. They're meant to be short-term, highly focused, and really collaborative with the therapist. It is not a passive intervention. This is a visual of explaining sort of that link between thoughts, feelings, and behaviors. And this is called the CBT Triad, because what we're really talking about when we're teaching this to patients is the connection between what I think, what I feel based on what I think, and then the behaviors or the actions that I engage in. Now, the things that we do talk about as well is the triggers, right? The environmental things, the things outside of the person that impact that thought. So something happens, I have a thought about it, then I have an emotion about it, then my body responds a certain way, and then I engage in an action. You can see these arrows are bidirectional. So that means that it can go in either direction. So when we're doing CBT, we're trying to intervene on either what somebody is thinking or what somebody is doing. And we're going to get change in either direction in terms of their emotions and their physiology, how their body is responding. Because we're not going to directly impact the emotion or the physiology of a person. With CBT, what we're focusing on is the cognition and the behavior. If we can get change on either of those, or really ideally both, then we're going to see change in the entire system. And so that's what we're focusing on with CBT. These sessions should really be highly structured. And there's a 20-20-20 rule in terms of if you're going to provide a traditional CBT session or multiple sessions, you're going to want to block 50 to 60 minutes and break each part of the session into 20-minute sub-sessions. And I'm going to talk about what that looks like. So the first 20 minutes, and this is true for every time you're applying CBT, you have an agenda. You're going to briefly identify what's going on with them currently. So what happened in this past week that could be connected to that agenda. And you want to get information about their cravings or use since the last time you saw them. And you review any practice that you may have assigned prior. If you haven't assigned practice, you can skip that part. But the first 20 minutes is always the same. You set the agenda, you review briefly what's been going on with their use, with their life in general, and then you review any practice that you might have assigned prior. The next 20 minutes is where you introduce the active kind of intervention. So when in a few minutes, when I get to showing you some examples, let's say you're doing trigger identification, you'll provide that in the sort of the middle 20 minutes where you'll actually go over, this is what it looks like to identify triggers. Let's do a worksheet together. And then you'll have them actually practice it with you. And then that will be part of assigning homework, which is in that checking for understanding last 20 minutes. So that's where you'll explore their reaction to what they practiced, to the skill that you introduced, and you'll assign for them to do it next week and then review any high-risk situations that are coming up for the next week or between now and the next time you see them. And so that's how you break up the hour anytime you're doing traditional CBT. Some of the challenges with this approach is it can be really difficult to stay focused. These interventions are really sort of directive, and sort of they're focused on one specific thing or one specific activity for that day. And oftentimes clients that are used to more traditional therapy or traditional types of interacting with providers can come in with a whole host of problems, and they don't necessarily want to stay on task. And so that can be a challenge. The other thing is, you don't want to do this overly directive. So you want to have a flexible enough style that you're not mechanical and invalidating them. You're integrating what their lived experience has been up until that point and what is going to be meaningful to them with the education of the skill that you're providing. But you also want to stay on target. So setting that agenda, sticking to that agenda is really important. So some of the things to keep in mind with doing good CBT, regardless of which intervention you're using, is the importance of repetition. Obviously, they've done a lot of repetition to end up where they are now. And with CBT, what we're teaching them is a new approach to that system, to changing their thinking and changing their behaviors. And that can be really difficult. And so you want to repeat, whether it's repeating the same technique or intervention multiple times. You can repeat whole sessions, parts of sessions. The important thing is not that you're moving through a protocol, but the important thing is that they're actually learning the skill that you're trying to teach. And so don't be afraid to repeat as much as possible. The other important thing is to make sure you give a clear rationale. If people don't know why they should do it, or they don't know why it would be helpful for them, they're not likely to practice it or use it. So you can just sort of assume that that was a waste of breath in teaching it, if it's not clear to them what the rationale is in terms of the usefulness for them. So it's really, really important to clearly explain and connect the dots why this is going to be helpful for them, and even elicit that from them. Why do you think it would be helpful for you to learn this skill today? The other thing is monitoring. A lot of CBT is practice outside of the times that we see them. And so we have to take ownership of that too. We need to monitor their urges, their cravings, their use, give them means of monitoring that. And anytime we assign any practice, that first 20 minutes, we have to check on it. Was it done? Why wasn't it done? Problem solve it. Because if we're not monitoring, we're not going to see that change over time. And then we also want to make sure that we're praising approximations, because change is really hard. It can take, it can be overwhelming to people to think like they're not living up to their own expectation of themselves, the expectation that they think you have of them. And especially when it comes to practice or homework, that can be really challenging for people based on their previous experiences. And so any positive change, any step in the right direction, we want to give tons of positive reinforcement. Even if it's just coming to meet with you, even if it's just, I came in today, I did nothing else, but I came in, that's still something that can be praised. So we want to make sure we're always giving that positive reinforcement. And then the last big thing is overcoming obstacles to practice, because that's really where the skills sort of fall short, is if they're not doing it outside of the times that they're working with you. And so you can't forget to reinforce why it's important to do that practice, and being mindful with the language that you're using. So if they're saying, I didn't do the assignments, I couldn't do the assignments, saying, okay, I totally understand. How can we make it easier? How can we make this achievable? What needs to happen to prioritize it? What's getting in the way, right? That we really get into the nuts and bolts of helping them to move through the practice so that they're doing it. Because if they're not practicing it in between seeing you, it's not going to be a useful skill. Okay. So now I want to show you some examples of CBT-based relapse prevention exercises and some actual worksheets, and sort of help flesh this out for you. So one of the primary things that we do is trigger identification. And so that means you're teaching the skill of helping them understand their external and internal triggers. So what are the thoughts that trigger the behavior of using? And so the first thing is explaining to them there's always a trigger before there's use. And in fact, there's several things that happen before we actually get to the behavior of use. Something happens either in my environment or in myself internally, which could be an emotion, could be a trauma memory, but there's some sort of internal or external trigger that creates a thought. I can't handle it. I'm not good enough. It's never going to change, which then triggers a craving or an urge to use, which then is followed by engagement in the behavior of use. So where we're going to try to intervene is understanding what those internal and external triggers are, so that we can then identify what's the thought connected to them, and manage it at the thought and the craving level before we ever get to the use behavior. And we want to explain to them very clearly that this is a normal part of classical conditioning or learning in general, that as they developed a substance use problem, hundreds of thousands of things in their environment got linked to the effect of that drug. So this is happening all the time as humans. When we engage in substance use, all the variables around thinking about procuring, preparing, and actually using that drug get connected and become triggers. And so we have to make a pretty exhaustive list of all of that environmental stimuli. They say it in 12-step language, the people, places, and things that are potentially triggering the thought and the craving, which then leads to the drug use, right? So we want to do a really thorough, what's called functional analysis of the drug set and setting to begin to identify these triggers. And this is what a functional analysis would look like. And this is something like a homework sheet that you could give to a patient to have them start to identify what are the external triggers, who are you with when you use, where do you use, when do you usually do it, what are the internal triggers, what are you usually thinking, feeling physically, feeling emotionally that's connected to that use. And you don't even have to complete the rest of the worksheet. You could spend a lot of time just identifying what are those external and internal triggers, and then over subsequent sessions begin to link it to, okay, what is that connected to in terms of the use behavior, and what is that connected to in terms of the long-term and short-term positive and negative consequences. So that's part of trigger identification. Behavioral contingencies is another intervention category that would fall under CBT relapse prevention. And that's where we're looking to understand the connections between, once we get to the urges piece, and actual using. So there are things in the environment that once we get to that urge showing up, or the thought level showing up, what can they change behaviorally to do instead of using? And so this is where we would explain to patients that people respond to consequences, both positive and negative. So punishment works, and even self-punishment, people will fall into that category really, or that pattern really easily. Like if I just punish myself enough or say enough negative things to myself, I won't engage in that behavior. It does work, but it tends to not work that well. And it tends to not work for the long term, have lasting effects, the same way that rewards do. And so we want to help people understand that if they're going to apply contingencies to their life, they need to first identify what is the behavior I want to change, right? Maybe I want to show up to treatment more often, or maybe I want to stop using or use less. And then what am I going to link that to, both in treatment or in my actual life, so that I'm getting reinforced for the new behavior. So one activity you can do that's part of that you can assign to someone to do at home would be an alternatives to use. So having them identify what's the triggering situation and what's the actual reward or the positive of using that they're getting. What are they getting out of engaging in that substance use in that triggering situation? Because there's something that's very reinforcing there that we want to identify. And then what could you do alternatively that would have a similar or same positive consequence? And you can see that in this example, you might have to list more than one positive consequence, because there are very few things in life that are going to equally substitute for the effects of a drug. So we might have to pile on 3 or 4 different things that they have to do to get a similar outcome. But it's helping them to shift out of this idea that punishment is necessary, that they can actually reward themselves for doing something different. And what would that look like? And let's strategize really specifically and come up with a plan that they can have an alternative for using instead of just the absence of use. So that's contingency or behavioral contingencies. Urge management, as we think about that chain, that we have a trigger, and we have a thought, we have a craving or an urge, and then we have a using behavior. So urge management is we're moving down that chain, and we're trying to intervene at the level of the urge. So when the urge shows up, which is really the thought I want to use, or thinking about an image or something that's connected to using itself, intervening at that level before it actually turns into the use behavior itself. Now, how we start that is by making sure that we're tracking correctly the urges, and then we can teach them the skill of managing the urges. So we first need to have them start to regularly record how often they're having an urge to use, what is the intensity of it, so starting to actually rate it between 1 and 100, and then what are they doing naturally. And maybe the first week that they do this, or first couple times that they do this, they're not going to put anything in the coping behaviors. That's okay, right? That tells you, oh, I have some teaching I could do here to give them alternatives for when the triggering situation or thought or feeling shows up and they have the urge. How often is it happening, and what intensity is it happening? And if they have nothing that they're doing to manage it, now I can move into teaching them some urge management skills. Here's another example of a monitoring log that links actual use with urges. So there's another way that you can start to track both. You don't have to track either or. And then once you've identified, okay, urges are happening, they're a natural part of change, right? We just need to teach them the strategy to cope with it, to manage it when it shows up. And so one strategy is called urge surfing. And that's where you explain to the patient that it's just like surfing a wave on the ocean, that you're not going to be very successful if you barrel into that wave. You're going to get buried, right? Versus if you can surf on top of it, the wave's going to come, it just keeps coming. But if you can float on top of it, it's much easier to manage, right? So you're just helping them to understand that's what urges are. They're going to show up, but they pass. And they typically peak within 20 to 30 minutes. So even if you do nothing but avoid leaving your space, you just ground yourself to your chair for 20 minutes, likely that urge will pass completely on its own, and it will come back. But every time you don't give into it, every time you avoid using when that urge is present, it gets less and less powerful. So it's kind of like the ocean calms and quiets itself over time. It becomes weaker, and they tend to show up less often, right? So learning to identify when the urge is there is really part of the tracking process. And then we can, there's a whole slew of other activities that you can do with urge management that are helping people to intervene in that 20 to 30 minute space when the urge is really strong and it's shown up. There's a number of different strategies in CBT that can be used in this category. And then lastly, high-risk situation planning is a really vital part to any CBT that you're doing or any relapse prevention that you're doing. Just like trigger identification, you think about high-risk situation identification as it's not a single variable, like seeing foil or the driving past the street where my dealer's house is. That might be one single variable, but a high-risk situation is an actual situation that's filled with variables that are likely to trigger high-intensity urges to use and put the person at a really vulnerable place. And so they need to have a plan to get out of that situation or to manage that situation Just like we have plans for like if there's a fire in our building, if you work in an office building, you probably have to do fire drills and know where your emergency exits are. If you stay at a hotel, it's the same thing. The reason why that's laid out for us is so we know what to do in case of emergency. So what we're teaching them with high risk situation planning is that all situations can be categorized into either high risk or low risk. And people that are early in recovery or moving through recovery tend to spend a lot of time in high risk situations, understandably. And we're wanting them to start to shift that balance where they're spending more and more time in low risk situations. And when they are in a high risk situation, they can identify it clearly and have a plan to move through it. So every week that you meet, at a minimum, if you go over a worksheet like this with somebody and say, okay, between now and the next time I see you, what situations are coming up that are likely to trigger you to use, or that if you're in that situation, it's going to be nearly impossible for you to avoid using. Let's list out those situations that are coming up and brainstorm some plans how you're going to handle them. And you give them, 3 to 4 alternatives, have them carry this with them, take a picture of it with their phone, have it on them. So when they find themselves in that situation, they're not having to react based on something that's well practiced, because they don't have the practice to manage it. They actually have a plan that they can pull out and they can follow to escape or avoid that situation effectively without using. And so helping them to really have this clear, and that this is something that they should be doing every single week as part of their recovery is a really vital relapse prevention piece. And that goes hand in hand with just using a plan in general, like coming up with weekly or even daily or hourly schedules so that their time can be accounted for and they're not inadvertently falling into a large number of high-risk situations and just setting themselves up for failure, essentially. So that was a lot of information about CBT and relapse prevention in a nutshell. And I know